So they all have trunks. Yeah. All right, we might jump into it. First off, thank you all for coming. I know this is a stressful period in the year, and there's a big recording button next to me, so welcome to everyone who's listening as well. My name's Ben. I'm doing my PhD over at Monash at the moment. And I just thought I'd start off by saying you guys will eventually graduate before me. So please sign my logbook when I'm your intern, or when you're my intern and I just want to go home in 5th year. All right, so we'll make this up. So today I'm going to talk about paediatric surgery, but I think there's probably two parts. There's very osseable stuff and very managementy stuff at the start, and so I'll probably spend most of my time talking about that. And then there's kind of all the pediatric surgery conditions, and they're very buzzwordy and sort of MCQable. So my talk today, I'm hoping there's no like pediatric surgeon in the audience because they'll have a heart attack. It's very 4th year OSCE MCQ focused, which hopefully is up your alley. So we'll start off by meeting Travis. So Travis is an 18-month-old with a 2-day history of significant vomiting, and he's got a 4-year-old brother at home with gastroenteritis. So I'll give you, I said 2 minutes, but under time, we'll give you just maybe a minute. Just quickly think, maybe with the person next to you, what's the most likely cause? What do you need to know about his vomiting to best handle this station? What can't we miss, and what are we going to probably end up managing? They're like the questions you ask yourself in your 4 minutes reading time, if you still get it. So have that time quickly. All right, that's about a minute. That's like the most talking I've ever heard when I've done this lecture. So like that's all well done. You obviously all have all the answers. So really, what do we need to know? I mean, straight off the bat, you've got a kid at home who's coming with vomiting, who's got a brother at home with gastro, yeah? Like the first thing you'd put up on your blank bit of paper for your reading time is probably gastroenteritis, yeah? The thing to know about gastro, though, is that gastro is probably a diagnosis of exclusion, given that ped surge is quite heavily osseable. So when you think about the vomiting that you want to ask a bit more specifically, you want to know whether this is like possets and regurg. So that's like that milky sort of vomit that they just sort of, it's non-forceful, it just sort of comes up. Is it like true vomiting where they often bring up lots of food? Or is it like projectile vomiting, and do you have a pyloric stenosis case coming up that you need to manage? Then sort of like what is in the vomit? Is it that milky posset regurg pattern? Is it normal food, or does it have bile and blood in it? And am I going to need to make this sort of surgically oriented in terms of the history that you're going to take? So pretty simple questions in terms of what the vomiting is going to look like. Then you sort of start to think, well, can I sort of start to work towards a cause of the vomiting? So if it's a big one is sort of infection, and particularly with kids, infection anywhere can cause vomiting. So obviously there's your general symptoms like your fever, your sick contacts, coryza, lethargy, and you really don't want to miss sort of sites like the brain, ear, nose and throat, the lungs, the gut and the urinary tract, and you'd sort of target your history, a few little specific questions to rule out those areas. The other really common cause for vomiting are sort of functional causes, which you probably touched a bit on this morning, but this is going to be like they're going to have been vomiting for a much longer time course. It might be that sort of possety type pattern, and they may sort of have an urticarial rash to suggest that maybe this is sort of some sort of intolerance. maybe it's reflux, celiac disease. And you can see that these two pictures between even just infectional and functional causes are going to look quite different. Wonderful. Then the other thing is this could be anatomical. And I guess with Ped Surge, this is the type of picture that we're going to end up getting. These guys are going to have a much more acute onset. They may have blood or bile. It may be sort of a projectile picture. They're very stressed. The parents are often very stressed as well. And they may have sort of changes to their stools as well. We'll go through these later on. Cool. So then there's the other things that you want to have a look at. So maybe just rule out things like head trauma. If they're a little bit older, you can ask about an aura, and then think about polyuria, polydipsia for kids with diabetes. Cool. So I wanted to go through sort of your approach to vomiting, because I think that's kind of the context that you'll get asked in OSCE station when it comes to Ped Surge. So in Travis's case, he has a fever of 38.5. He has no suggestive history of a focal infection. He also has loose bowels. It's what I call normal vomit, but there's no bowel, no blood or mucus, and he's got a bit of lethargy, tummy pain, and he's had minimal to eat or drink. I've also chucked in there his weight, which is 15 kilos. He's 18 months, so that's freaking heavy. But it will make the calculations a bit easier later on, so you just bear with me. So really, your most likely diagnosis for this kid is gastroenteritis, yeah? But what else is going to be really important? And you have the slide, so someone humour me and give me the answer. What else is really important with this kid that we're going to have to end up managing? Yeah, dehydration, wonderful. Yeah, so he's had minimal to eat or drink. So I think really good students will be like, he's got a history of like a really high risk infection history, but I think really good students will go, all right, well, what's the effect of all of this fluid loss? He might be dehydrated. They'll then go on to ask a few questions about his hydration status. So when we think about taking a history for dehydration, it's really, really quite simple. Or the way I do it is quite simple anyway. You really just ask about fluid going in and fluid coming out. Yeah, so you ask how much have they been drinking or feeding. When you talk about fluid going out, how much diarrhea, how much vomiting, how much urine, have they been sweating and things like that. And really, this is just going to give you a clinical picture to think, well, how dehydrated are you? It's also really good to ask about wet or dirty nappies. Obviously, it's high risk if they haven't been having lots of wet nappies that they may be more dehydrated. Then on examination, I've probably just listed the findings here for you. If you got asked in an OSCE to go through a dehydration exam or something like that, or look for the signs of dehydration, you sort of start by looking at their mental state. So you're really worried if they start to get towards floppy, looking at their weight. There's some really good charts on the RCH guidelines about how dehydrated and estimating the percentage fluid loss that kids have. You'll probably come to term that I kind of like just breaking out as simply as I can. So the way they do is if they've got a high risk history, so if they've been vomiting and whatever, but when you do an exam, they kind of look fine. So they've just got a high risk history. They're probably about 3% dehydrated. If they've got a few clinical symptoms, so maybe they've got dry mucous membranes, they're a little bit dry on the tongue, they've got a high risk history, but nothing really else, they're probably about 6%. And then if you're getting into like severe dehydration, changes in mental state, they're about 10% dehydrated. And this will become really important when we talk about rehydration. All right, then you sort of look at the capillary refill, look at skin turgor, and obviously vital signs are going to be really important, as well as looking about dry skin, sunken orbits or fontanelles in really young ones, and dry mucous membrane. So just a good sort of list there to sort of think about it if you need to particularly look for the signs of dehydration in a kid. Very similar to what you would look at in adults. All right, so Travis, so on examination, he's lethargic, floppy, he doesn't engage, he has dry mucous membranes, he's obviously progressed quite significantly since the start, which will often happen in your OSCE. He's had slow capillary refill and he's had very little oral intake. So again, quickly, maybe just a minute with the person next to you. The next part of the station is, well, based on this information, how are you going to rehydrate? Terrence. I've got Terrence, but it's Travis. All right, we'll keep going. So again, really good, lots of discussion. So when we think about managing dehydration, I mean, rehydration and fluid management has in the past been something that I struggled with a lot. So again, I sort of broke it down into three really important bits that you need to decide. So really, you just need to decide, well, before I even decide what fluids I'm going to give, how are you going to give it? So then you need to decide what fluids are you going to give them and how much of each one. So when you think about the route that you're going to use, so there's really only three that you can choose for. So the best one to do, or the first line one that you would look for, is orally. If they can tolerate breastfeeding, that's great. Otherwise, you think about using sort of small, regular feeds, and with anything that you can get anything that they're going to tolerate, particularly clear fluids, and avoid things like fruit juice, soft drinks, sports drinks, those sorts of things. If they're not going to tolerate oral feeds, and probably with this kid, they're probably with Travis or Terence, whichever they're called, they're probably not. So then you would think about, well, maybe we can use a nasogastric tube. And that's usually the second line one, often because it helps with the vomiting a little bit. They've sort of found that if you can sort of slowly drip in fluids down a nasogastric tube, it helps settle some of the inflammation in the gut and helps settle some of the vomiting. And it also lets you give an antiemetic. And the antiemetic most commonly used in kids is ondansetron. I kind of remember that that's the one used in kids because it kind of sounds like a transformer, like ondansetron. So that would be what you would give for kids. And then the next line one is often if they're not going to tolerate an NGT at all, you'd go for IV fluids. And I think in the context of pediatric surgery, this is probably what kids are going to come out of theatre with. So it's important to know how to sort of use all three routes, even if you're not going to be managing severe dehydration by yourself. So on examination, Travis is lethargic and floppy. He doesn't engage. He's got dry mucous membranes, reduced skin turgor, blah, blah, blah. He's a really crook. So the most likely thing we're going to use for him initially is we're going to be giving him IV rehydration. So when we think about the three fluids that we can give, you really only need to know three. So there's just normal 0.9% salty water, normal saline. There's normal saline that you've added 5% dextrose, so just a little bit of sugar, and normal saline plus 20 millimoles of KCl. And so KCl is really just to help with electrolytes. And so really you just need to know those three and when we're going to use each of those three solutions. Okay, so now how much? So there are really two parts. If they're hemodynamically unstable, you're going to need to get fluid into them really, really quickly. So you're going to need to give them a bolus. And then each kid is going to get this triple whammy, not the triple whammy that's going to destroy their kidneys, just three different calculations of fluid loss. So when you do a bolus, so we think, all right, so it's when they're hemodynamically unstable, we give a 20 ml per kilogram bolus, and the fluid that we use for bolus is 0.9% normal saline. Yeah, so really, there's probably not much more that you need to know for that. I mean, you can give the 20 ml per kilogram bolus, you can then reassess them. If they still need another one, you give it again. It kind of makes sense. But just important to know that if you're giving bolus to kids, we use normal saline straight up. Then this is probably what most kids, if you're having to write up the fluids for a kid who's come out of theatre, this is probably what they're going to end up getting. They're going to be getting the deficit, which is basically like when a kid has been vomiting or has lost a whole lot of fluid, you've just got to replace almost in the first 24 hours what they've lost. So you replace the grams of weight that they've lost in mils of fluid. We said before that the RCH has got those really good guidelines, but there's a nice way to just estimate how much they've lost. So if they've had no clinical features, they're about 3%. And so you use their previous weight and you go 3% of their weight, work out how many grams they've lost, and you just replace that in mils. And you sort of adjust that to how severe their dehydration is. So for Travis, this is why I used 15 kilograms, because it's nice and easy. He's got pretty severe dehydration. So he's probably lost about 10% of his body weight in terms of his dehydration. So of his 1,500 gram total, he's probably lost about 1,500 mils or 1.5 litres. And so you replace the deficit over the first 24 hours with 0.9% normal saline and 5% dextrose. Yeah, pretty simple. Also, stop me, and if I'm going too quick, let me know, and I'm happy to explain anything in more detail. Cool, so you replace what he's lost. Yeah, sorry, question. Yeah, wonderful. So the question was, is this in addition to typical maintenance fluids? It is. So this is like probably on the first day when they've just come out of ED, they've been vomiting heaps, and you go, all right, so he's probably lost his 10% of body weight, and you give that 10% over the first 24 hours. And then a wonderful segue into, well, the next part that we also add on to that is we start what he would just need every day anyway. Wonderful. So daily maintenance fluids is basically, like I said, just what they need every day if they're not taking any fluids in orally. And you can use this 150-20 rule, which quite simply is for the first 10 kilos of their weight, they need 100 mils per kilogram. And for the second 10 kilograms, they need 50. And for every kilogram after that, they need 20 mils per kilogram of fluid. So when we talk about how much fluid they're going to need each day, or their daily maintenance fluids, we use this normal saline plus 5% dextrose as well. So Travis weighed 15 kilograms at his last check 2 weeks ago. So the first 10 kilograms, you give him 10 mils, and for the next 5, you give him 50 mils per kilogram, which is 1.25 litres of normal saline plus 5% dextrose. So then on the first day, you'd be giving him his deficit, which is that 1.5 litres, plus his 1.25 litres of daily maintenance fluids, and that's what he would be getting on day 1. And then on day 2, he would just be getting his daily maintenance fluids. Is that, I mean, a little bit of maths is pretty shit on a Saturday morning, but hopefully that's not too tricky. All right, and the only other thing, and this will probably tie in nicely with your management, is with a kid who's been vomiting and had lots and lots of fluid loss, we also need to be worried about their electrolytes. And so part of your management will be like, all right, I'm going to start a fluid balance chart and get the nurses to monitor the wet nappies. And then for every approximate, this is obviously quite rough, but for every mil lost, we replace it mil for mil with 0.9% saline plus those 20 millimoles of KCl. So really the 2 you need to know: for the bolus, we're using just normal saline. For the deficit and the maintenance fluids, we're using the normal saline with the dextrose. And for the electrolytes and the ongoing losses, we use the KCl. Happy? Blank faces is always good. Okay, so that's fluid management, and we'll come back and touch on that a bit later. But I think it's just really good because you never really get taught sort of hydration and fluid management for kids, but when in an OSCE or in sort of management type stations, you're going to be talking a lot about hydration. So it's good to have a bit of a knowledge that, all right, I'm going to be thinking about boluses, daily maintenance fluids, and ongoing losses. So now we're sort of thinking, well, we've thought about his dehydration, but what if the cause looked more like this? What if his picture, he sort of had an acute picture, he had blood, projectile vomiting, he was super stressed. Maybe it's a surgical case. So then it's really important to work out the cause. Yeah, sorry, question.
Would you put a catheter in and do a script fluid, or is that not appropriate given the age?
So the question was, would we put a catheter in for that for that previous case? Look, don't quote me, but I probably wouldn't. I think with a kid with severe gastro and severe dehydration, you would just monitor fluid from wet nappies. You're going to be giving him IV rehydration anyway, so you're pretty confident he's going to be getting enough. And then you would just monitor any ongoing losses approximately. But good question. Cool. So then if he, instead of a gastro picture, if instead he had a, excuse me, if he had more of an anatomical type surgical picture, then we need to think about the cause. Now, again, there's a bit before we get to the working out the actual pathology, but I think there's quite a few nice little clues that you can use, particularly for MCQs, to work out, well, what's the cause before I even look for a buzzword. So the first one is his age. So I use this timeline quite a lot. So within the first, so birth to 2 weeks of age. So within the first 2 weeks, 2 weeks to 2 months, 2 months to 2 years, and then sort of 2 years to 5 years and 5 years onwards. Now, you'd be surprised how nice it is if you look at a question and the kid has some sort of abdominal history and has one of these age groups, how easily you can just pick the MCQ without even looking at the symptoms. So, I mean, that's horrible. That's a terrible way to be a doctor, but like, we're not being doctors at the moment, we're being 4C medical students. So you can learn to be a doctor later. Oh my God, I can't believe I'm saying this. It's horrible. Stop the recording. All right, so birth to 2 weeks. So within that first 2 weeks of life, it's like congenital things that are already there during development, or like super duper severe stuff. So things you really don't want to miss. So these are things like duodenal atresia, so the small bowel didn't grow properly, malrotation, Hirschsprungs disease, meconium ileus, or neck. Yeah, so they're the things, problems going wrong in the first 2 weeks of life often attract really high attention because they're really quite severe. Anything after that is kind of like progressive things that go on to develop slowly and tick over. So if it's sort of in the first 2 weeks to 2 months of life, it's most likely pyloric stenosis. If it sort of develops within sort of 2 months to 2 years, you're most likely thinking that this is sort of like an intussusception type picture. 2 years to 5 years is sort of intussusception or kids starting to develop appendicitis. And then 5 years sort of into adolescence, it's sort of more likely to be appendicitis, testicular torsion, or Hirschsprungs disease. Should focus again, this is all about clues. This is not a spot diagnosis. This is sort of about when do these sort of conditions present in terms of a kid's age. Okay, the other clue is sort of, well, what type of clinical picture do they have? Do they have like a very sort of small bowel, stomachy, upper GI type picture? So this is going to be those things like pyloric stenosis, small bowel atresia, malrotation of the small bowel, and intussusception. These guys are going to present with their big presentation picture is going to be vomiting. Yeah, if they have bile in the vomit, it sort of suggests that the problem is sort of just below the ampulla ovata, just below where the biliary tract drains in. And the investigations that you're going to do is going to obviously do an abdominal X-ray, and you may think about an upper GI contrast study. If in sort of opposition to this is if they have more of like a lower GI type picture, like something like an incarcerated hernia or small left colon syndrome or Hirschsprungs, they're mainly going to present with like abdominal distension, with sort of distension and pain. They're going to have less likely to have vomiting because the problem is low in the GI tract. But the major thing is they're going to have abdominal distension. You're still going to do an abdominal X-ray. All right. In both cases, we're going to be doing an X-ray, and this is just sort of like very, very 101 for abdominal X-rays in kids. Normally, the way that you tell the difference between small and large bowels on X-rays, you look for like the haustra of the large bowel and the valvulae comitentes or whatever they're called. Anyway, you can't really do that in kids because their bowels haven't developed properly. So what you really do is you go to the level of the umbilicus, which is like L4. If they've got that sort of proximal type picture, that small bowel type picture, most of the pathology that you can see, or most of the distension, is going to be above the level of the umbilicus, high in the gut. And they have what's called, or what Monash calls a scaphoid abdomen, which is really just more distension sort of up towards the top, and it sort of is a bit narrow down towards the bottom. Sort of the opposition to that is if it's more of this sort of lower GI type picture, they have this, most of the bowel loops are below the level of the umbilicus, and you might be able to look down into the rectum and sort of see gas sort of toward the rectum. All right, one more thing before we actually get to the pathologies, and this is your basic management for all surgical type patients. So the way that I go through it is there are 2 talking things. There are 2 things you do orally, there are 2 things you give IV, and there are 2 medical things that we do. So the 2 talking things is you're going to be referring them to Ped Surg, because as we sort of said in the last talk, you're an intern, you don't know what you're doing, so you involve your seniors. And I think that's a really important point to understand. And you're also going to be explained to the parents. So refer to Peds, explain to the parents. The 2 oral things is you're going to start them nil by mouth because they're going to potentially be going for surgery. And you insert a nasogastric tube. Then you're going to secure IV access and take baseline bloods and start IV rehydration. So making sure at least that they're rehydrated, ready for surgery. And like, bam, you're all over this because we've been through that. And the two medical things is you start them with some basic analgesia and an antiemetic. So I think like really, hopefully by now we've covered like some really important principles that like, even if you don't know the diagnosis, like there's like, even if they're half a mark each, that's like 4 marks for your management station, probably out of 5 that you can just smack out without knowing that you treat a pyloric stenosis with a Ramsted's pyloromyotomy or whatever. Like you don't need to know the specific surgery, you just know basic principles that will get you through sort of safely and simply. Okay, now pathologies. Now we'll get some buzzwords that'll help you. All right, so with duodenal atresia, we said that it's a congenital problem, so it's going to present probably within the first few days of life. And I think pictures speak louder than words. What really happens, atresia just means sort of malformation or blocked lumen. So you have a piece of the small bowel that just didn't grow, and the lumen is just non-continuous. And so what happens is that these babies just eat, and food goes down and it hits that sort of congenital blockage, and then it just comes back up and they vomit it all up. So they're going to have, I'll just go back to that picture. Often the bile duct drains in sort of just above it, and so when they vomit, it often comes back up with a little bit of bile. But because there's no sort of acute inflammation or there's no piece of bowel isn't infarcting, they're actually often not that well. They just vomit. They have bile in the vomit, so they're like that well-bilious vomiter. There's some associations with Down syndrome, which I think is 30%, I've said. We'll go with that. Then the investigations, what you do, so is when you do an abdominal x-ray, very big buzzword is they have the double bubble, which we had to interpret in our OSCE. And so you can see the double bubble is really just, they have a really big dilated stomach and they have a little piece of dilated small intestine, which creates those 2 bubbles. You could also do an upper GI contrast study, but often it's diagnosed on abdominal x-ray most often. So your management for these kids is like, bam, that's those 8 things. So the 2 talking things, your 2 oral things, your 2 IV things, and your 2 medical things. And then the surgery name is a duodenojejusectomy. So it's basically just you cut out the bit and you join them back together. Yeah. Post-operatively, you're going to always make sure that the parents know they're going to have regular surgical follow-up, and they're going to be seeing medical practitioners, mostly their GP, quite often. Yeah, so that'll be the structure I'll go through for most of these pathologies, but really you just sort of need to know like what's happening, what's the main problem, how am I going to see it, and then what's the surgery name in addition to my basic surge workup. Okay, so malrotation with volvulus. I think when I was learning this one, I had way too much fun because you can go super embryological. So really what happens is when the gut is forming, it sort of goes through this particular sort of like folding process where it twists around. And the most important thing, don't worry about that picture. The most important thing is this bit, yeah? So you know that your omentum or that sort of fatty, fibrous tissue that sort of surrounds your gut, the most important thing is that it normally has this nice big wide adhesion to the back of your abdominal wall. And that big sort of wide band of your that supports your small intestine stops it like twisting and wrapping around on itself. What happens with kids with malrotation with volvulus is that nice big wide omental band doesn't form, and it's really, really narrow and is predisposed to sort of twisting on itself, and you end up with this like sort of twisted small bowel. And so that's the volvulus. So there are really those 2 parts. There's the congenital part, the malrotation, and then there's the volvulus part that the kids present with. So the most common picture is because the small bowel is twisting, that obstruction happens below the ampulla ovata, so they present with acute bilious vomiting. They often have this, now they've got this acutely infarcting, inflamed piece of small bowel, so they present with obvious discomfort. They draw their knees up. They sort of go back into that sort of fetal position. They're really, really uncomfortable. So you do an abdominal x-ray and you'll see that there's sort of like no real gas down in the rectum. They might have a bit of a distended stomach, but nothing really pathognomonic. And the diagnosis, the gold standard diagnosis, is an upper GI contrast study. And you see this corkscrew appearance. So you can see like this big thing here is the stomach. And you can see that it's sort of like rotated right over. And apparently like this is what the radiologists call like the corkscrew appearance here. Okay, so the management, bam, there's like your standard management, and then you've just got to know the surgery. So the surgery is called a LAD procedure. The LAD procedure is they basically just go and they recreate that nice wide band for the small bowel. And then this is obviously major, major abdominal surgery. So these kids are going to be followed up for a long, long time. That's what happens. Okay, Hirschsprungs disease. So again, Hirschsprungs disease, the problem that's happening, oh no, in the picture. So basically what's happening is when the bowel is forming, the myenteric plexus, or those nerves that innervate the muscle of the bowel, they develop from proximal down to distal. And what happens in Hirschsprungs disease is those distal segments of the bowel are aganglionic, or they don't have any of those myenteric neurons in them, and they therefore don't push stools down through the bowel. And so they develop this awesome megacolon, which is just a nice name, but probably not very fun to have, where because that last section of the bowel doesn't have any of these neurons, the proximal bit just accumulates stool and gets really dilated and often really damaged if it's undiagnosed. So like most things in peds, it has an association with Down syndrome. This is that picture. This is just a picture of sort of what happens. That proximal segment gets really, really dilated and is where you can get a megacolon. So clinically, these kids, they fail to pass meconium. I think it's probably good to know the three sort of diagnoses for kids who fail to pass meconium. So delayed passage of meconium is within the first 24 hours. They haven't passed the meconium. And failure is denoted after 48 hours. So the three real things that we think about is obviously Hirschsprungs disease. We often think, could it be cystic fibrosis? So could this be like a meconium ileus or a meconium plug? And the third one is sort of congenital small left colon syndrome, basically a kind of like an atresia of the large bowel. Then, so in mild, it sort of can be like this spectrum of how big is that sort of aganglionic section. And I've seen on MCQs before that on PR examination, you get this squirt sign, which is, I don't know about doing PRs on kids, but you do, when you insert the finger into the bowel, you open up that sort of aganglionic section and the stools are released really, really quickly. It's a bit gross. There's a baby with abdominal distension, which is just cute. So the gold standard investigation for Hirschsprungs disease is a rectal suction biopsy. So they go into the bowel and they just take a small biopsy out of the muscle, and they're often looking for the absence of those myenteric neurons in that distal piece of the bowel. This is the abdominal examination. So again, you can sort of see that everything is sort of down low in the gut. So it's probably something quite distal. So the management, those baseline surgical workup, and the surgery is called a pull-through procedure, which is basically like they cut out the aganglionic section and re-anastomose the bowel to the anus. So necrotizing enterocolitis is the next one. So NEC is most common within the first 2 weeks of life. And really there were two major factors that these kids are going to have. So they're going to be premature, so their bowel is going to be a little bit susceptible to infection and inflammation, and they're often formula fed, which is thought to be associated with the immunity and the antibodies. Now really all necrotizing enterocolitis means is that you have a piece of bowel that started to die and there's an infective component on top of that that makes it happen even faster. It's actually not actually known all that well why it happens, which is really quite scary. So these guys come in often within the first 2 weeks, as I said, but they have this crazy sort of obstruction picture. They're really, really uncomfortable. They're septic, they're vomiting. Like these, it's almost like these kids are like, they're the worst of the worst type presentations. And it's not just in textbooks. This is what they actually look like clinically. And they'll be admitted straight to theatre because it's potentially fatal. If you, on bloods, they often have a metabolic acidosis because that piece of bowel is anaerobic and is just producing heaps of lactate. On abdominal X-ray, if it even gets to that, they have this pneumostosис interstitialis, which is a fancy word for saying, I don't know how well that's projecting. Oh, you can see it quite well. This part here is probably the best part of it. You can sort of see that the lumen of the bowel is this white line here, and you can sort of see there's this big piece of gas running up through the wall of the bowel. And that's just because the bacteria are producing all this gas, and it's just really quite inflammatory, and that is sort of accumulates in the wall of the bowel. So that's that pneumostosис interstitialis. Okay, the management for these kids, again, really those simple 8 things. They're going to get broad spectrum antibiotics and surgical referral. And I think that's probably all you need to know. They just have to get rid of that piece of bowel before it's potentially fatal. How are we doing for time? How long have I got? 5 more? Yeah. So the last one, or the last couple that we'll go through, so pyloric stenosis. It's really common. I'd be very surprised if you didn't get asked about it in some way, shape or form. So presents between sort of 2 weeks and 2 months of life. So right away, you know, it's going to be sort of something that develops pretty slowly. Probably the biggest buzzword in medicine is that this is that projectile vomiting. Like if you've actually seen it, it like clears their feet. Like it's super impressive. So on examination, they have this olive sign, which is kind of like the piece of the bowel, or the piece of the stomach, sorry, that's inflamed and hypertrophied. You can sort of feel during feeding. Because the main problem is that pyloric region of the stomach, that outlet of the stomach is hypertrophied and narrow. And so when they feed, the milk that they're drinking goes in, it hits that hypertrophied section and can't get through. And so then they just vomit it back up. And so the projectile part comes from when the stomach is trying to push the milk down through that narrowed lumen. Instead of pushing it through the lumen, it pushes it up and out the baby's mouth. And that's why it's so forceful. So the investigations that we do, it's often a clinical diagnosis. On VBG or venous blood gas, they have this very typical hypochloremic, hypokalemic metabolic acidosis. That's been asked lots of times. The hypochloremic, so low chlorine, is really just because they're vomiting so much and so regularly that they get rid of all of their hydrochloric acid, so they become hypochloremic. And the hypokalemia is often associated with dehydration, so they've got low levels of potassium, and obviously the alkalosis is because they've lost their stomach acid as well. Cool, so abdominal, so this is the X-ray findings, but the abdominal ultrasound is the best test. There's an ultrasound of it. I don't know how to interpret it. It's just what it looks like. But the management, again, these guys are going to be getting sort of that admission for surgical intervention. And the surgery that they do is called a Ramsted's pyloromyotomy. And they just get a scalpel and make a small cut in the sphincter, and that's all they need to do. Once it's been cut, it sort of often just self-resolves. But it's important to know that this is not an emergency, and they will often get followed up in the PEDS clinic, which is where you'll probably see them most. Okay, the last one that we'll go through is intussusception. So intussusception is that sort of telescoping of the bowel, or where one part of the bowel sort of swallows the next bit. Most of the time, we don't really know why this happens, but you can sort of see that the two parts of the bowel sort of overlap, and it's these sort of overlapping sections that all the blood vessels that are supplying the wall sort of get squashed, and you get a piece of sort of inflamed necrotic bowel. And so straight away you know that if they've got this inflamed necrotic piece of bowel, they're going to be presenting with that sort of acute inflamed type picture. If it's happening in the bowel, it's going to be that lower type picture. So they're going to have abdominal distension. They're going to be having that colicky, distressed type pattern. If by the time that piece of bowel is necrotic and starts bleeding into the bowel, they have that very buzzwordy red currant jelly stool, which looks like that, which is really quite gross. But on an abdominal examination, they have the buzzword of a sausage-shaped mass. I couldn't find a picture of a sausage-shaped mass, so I drew a sausage-shaped mass on a sick-looking baby. But yeah, that's what they find in MCQs. So the investigation that you do on abdominal X-ray, you have sort of that obstructive, that should be distal type picture, and a crescent sign. An abdominal ultrasound, they have a target sign, and really the target sign is just when they find on ultrasound that sort of piece of bowel that's gone inside another one, and even I can sort of make a target looking type picture out of that. Gold standard, both investigation and management, is what's called a gas enema or air inflation. And so they fill the gas, and much sort of like blowing up like a bowel balloon, they fill the gas and it sort of unravels that piece of intersuscepted bowel. So there's the baseline surgical workup, and there's that gas enema reduction. So most of the time, these will resolve within just one treatment. However, if they start to happen more frequently, they might undergo further investigation for reasons as to why they might happen. Okie doke. Testicular torsion is sort of a little bit outside the scope of ped surg, so I won't go through it much. I'll just let you guys do it in your own time. What I do want to say is just good luck. Fourth years is really tough, and I know I can just remember how hard it is coming into your examinations. You guys will all be fine. Like, I know that's a very easy thing for me to say, having been through it. But fifth year is really good fun to just sort of like remember all the things that you need, and to think about, well, like, how am I actually going to go and actually use all this stuff moving forward? So the light is at the end of the tunnel. You're nearly there, and I wish you all the best of luck for your exams. So thanks.